Hello, my name is Vani Konda, and I am a gastroenterologist. I'm the medical director at the Baylor Scott & White Center for Esophageal Diseases. I take care of patients with esophageal disorders, including achalasia and motility disorders, eosinophilic esophagitis, reflux, and Barrett's esophagus. Patients don't walk in saying, "I have dysphagia." Instead, they use a whole different set of vocabulary that might vary from patient to patient. Some people say they have trouble swallowing, other people say that food gets stuck, some people just feel nauseated, some people feel full early, but they all can represent esophageal diseases. Oftentimes, patients come to me after having had an endoscopy somewhere else, and they're told that it's negative, the biopsies are negative, and no one knows what's going on in terms of their esophageal symptoms. I think as endoscopists, it's really important we spend time looking in the esophagus, identifying the esophageal landmarks, documenting them, and then also looking at the esophagus and not just looking for a big mass or a big stricture, but look at information that can give us ideas about whether or not that esophagus functions properly. Even in the situations where we didn't get obvious information after the endoscopy, we might be able to gather information on the endoflip. Endoflip and manometry are both useful tools in my toolbox. I use high-resolution manometry as a standard test to assess esophageal function. Endoflip is different in the sense that it's a balloon catheter that we use to inflate in the esophagus, and it can actually simulate a food bolus, so that's different than the saline swallows we use with high-resolution manometry. The other thing about endoflip that's different is it's done during a sedated procedure, so the patient's not coughing or gagging, they're actually quite comfortable. We are able to do it during an endoscopic procedure and see the information real time. And that allows us to make real-time decisions and also give real-time feedback to the patient. And I'm able to assess in real time the esophageal opening based on the parameters such as diameter and distensibility. And I'm also able to assess the patterns of contractile response with the topography images that endoflip gives. I think it's important to understand there's only so much information you can get with specifically an endoscopy. And sometimes we do need to do further testing. And there is a role for high-resolution manometry, for endoflip, for pH testing. Everyone doesn't need everything, but a lot of times we do need more, especially when patients have persistent symptoms. I tell patients, I think of people like puzzle boxes sometimes. And sometimes things are pretty straightforward and you're just a 50-piece puzzle and it's pretty simple to put together. But other times you might be a 1,000-piece puzzle. And in that case, we might need more pieces of the puzzle. And the way we get that is with additional information like high-resolution manometry, like endoflip. And we might not get all our answers just looking at one piece, but when we're able to put all the pieces of the puzzle together, that's when we're able to understand what's going on with that patient.